Hopefully I can get through this in the next 6 minutes or so and just give you my approach on how I use radial access in the SFA. These are my disclosures. We know, I think most of us are very familiar with radial access, and I wanted to just emphasize why we would potentially use this in people who have PAD. I think the biggest reason would be potentially to lower vascular risk. Patients are definitely happier with radial access. We've seen that over the last several years, mostly because they can ambulate immediately. There are some issues with cost, and we'll go over that. But most importantly, it is a less invasive approach, and I think that's sort of where we want to go with most of our cases. And you guys can see many of these cardiology studies that we've seen over the years have shown that there's considerable benefit to doing this. So much so that there are some operators that believe, at least in the PCI space, that transradial access should really be the default. But what about PAD? We know from our experience over the last several years doing PAD cases, it can be very challenging. This is not a new concept. We were first made aware of PAD cases years ago with iliac artery stenting, but now we have other potential cases that we could tackle with radial access, including above the knee and even now below the knee. What are some of the advantages specifically for the SFA? Well, I mentioned low rate of bleeding complications, improved patient comfort, but it's also important to take into account your angle, particularly in people who have really diseased iliac arteries and very angulated iliac arteries. You can actually treat both SFAs in a single session using one access, which can be an advantage in certain cases. Also, people that have obesity and hostile groins. The problem with radial access for PAD, particularly the SFA, is that we do have a size limitation, number one, with the size of the artery, but also the size of the sheath that are made available to us. And I'm going to go into detail about the tools that are available currently on the market today. One of the big issues is really bailout, and we don't have great options for bailout. Some of the reasons why we would consider radial access: this is a popliteal SFA intervention. Obviously, we see these complications in some cases. This is a closure device injury after access into the common femoral. This patient presented afterwards with rest pain. This is an example of what I mentioned before about the angle of the iliac arteries. Clearly, there's an advantage in cases like this coming from above if it's technically feasible. How about this case, which is relatively common these days in diabetics and obese patients? To try to access the right lower extremity from the left side can be challenging, and this is an extreme example of that. What about patients that have kissing stents? This is something that makes it very challenging to do up and over if you can even complete this case, and so that you may be left with only antegrade access for these cases. And there is a select patient population that I believe benefits tremendously from radial access, and this would include people who are on anticoagulation, people who are coagulopathic, people that take Xarelto, which is very common now, and other anticoagulants. We've noticed, and we've seen this in several papers, where patients that have these medications on board have better outcomes with radial access. There are complications that we're very much aware of, including radial artery occlusion and radial arteritis. I did mention stroke here at the bottom. I think this is important to keep in mind, particularly in people with PAD, that the arch disease can be a contraindication to people going for PAD intervention for radial approach. The Barbeau-D waveform is important, although there is considerable literature now that suggests that maybe Barbeau waveforms are not as relevant as they used to be. So I'll just move forward. In terms of PAD intervention, in terms of where to access, this is sort of a great depiction of the styloid. But really what you want to do is go a little bit higher, particularly if you're worried about length of your devices. I always give a medication solution, which includes heparin, verapamil, nitroglycerin. Obviously, there's different ways to do that. And you do need to be aware of hematoma classification when you do these cases, particularly when you're giving heparin. This is an example of where we would potentially be worried about access. And so I'm going to go over what's available now and how we approach this. And we have a paper that we wrote last year, which really goes through these tools and specifically about what's available on the market. And I put this chart up. I apologize given that it's small, but really what we need to focus on is sheaths, Right now, we use the 6 French destination Slender, which is available in 119 and 149. It's completely hydrophilic and has great support. There's also a guiding catheter system, which is 120 and 150. In terms of guide wires, we have long glide wires now that are up to 450 centimeters, as well as the Viper wire, which goes in the mid 400s. In terms of balloons, we use 4 major balloons for radial access: Advanced, Pacific Plus, Ultraverse, and Metacross, and these can reach down to the tibial vessels as well. Stenting technology is limited, as we all know. The Entrust platform by Medtronic is available in 150, and then the Mizago stent, which is not currently available yet in the US, goes up to 200 and is rapid exchange. Atherectomy, the only system that's available currently is the CSI system. This is just an example of the radial sheath going in. This is the long destination sheath, which is completely hydrophilic, which we will put in over an exchange length wire after we get access. Just an example of atherectomy and angioplasty being used in this common femoral lesion in a patient with claudication. This is the just atherectomy plus plain angioplasty with Metacross, and you can see the final result in the next slide. You can get these case planning sheets and trying to figure out lengths to different target vessels, and these are available through several vendors. And that's the example of a 7 millimeter plain angioplasty with this rapid exchange.